Hi, I'm Jess Burke, Director of Marketing and Communications for the International Society for Heart and Lung Transplantation, and I am excited today to be interviewing Thomas Schlöglhofer, who's the recipient of the 2022 edition of the ISHLT and ICCAC's VAD Coordinator Career Development Award. Hi, Thomas. How are you?
Hi, Jess. I'm fine. Thanks
Well,
for having me today.
thanks for being here. And I guess for our first question, I shared your name, but please tell us a little bit about yourself, who you are, where you work, and what is it you do?
Of course. So, as you said, my name is Thomas Schlöglhofer, and I'm by training a biomedical engineer, but working already here since 2010 at the Medical University of Vienna, so located in Austria in Europe. Um, as I said, I worked many years as a VAD coordinator, but as my background is actually also a biomedical engineer, my institute always enabled me to do a lot of research, as you can imagine here, due to my training background. So I'm doing a lot of clinical duties, but of course, also research duties, and that's why I'm hired here at the cardiac surgery department. But I'm actively caring, of course, for the elderly patients, but doing a lot of studies, clinical, but also in vitro and in vivo trials in our center here.
Well, it sounds perfectly multidisciplinary, which is just how we like it. So, your project that you won the grant for, and congratulations on that, is using cold atmospheric plasma therapy for treating driveline infections in LVAD patients. So, tell us a little bit about how this idea came about, how you started on this research.
Yeah. So first of all, I think, as we all know in our society, I think over the past decade, I would say, the results of this therapy of permanently MCS became more established. I think we all agree on this, especially over the last years with the introduction of the fully magnetically levitated HeartMate-3. Also, if we look to the clinical arena, the clinical outcomes are basically getting every year better and better. So we have actually a pump already in place, which is having, as we call it, having really a nice hemocompatibility. So meaning over the previous years we had a lot of struggles with like pump thrombosis, bleeding, etc. So this was the major focus of research. But meaning, as we have now a pump available which have actually a nice design and actually more or less no more pump thrombosis, I think we as clinicians have or can actually focus now on other items. And as we know, I think the Achilles heel, I would say, still currently is that we do not have a fully implantable left ventricular assist device. So we still have the so-called driveline coming out of the body. And this is attached, as we all know, to the peripheral components, the controller and the batteries. And I think we also know that driveline infection, and which is caused by bacteria and biofilm bacteria, is really a major drawback. And it's one of the most common causes of readmission. It's leading, if we are not treating it, deep infections, of course, to death. And that's what we want to avoid in our patients. So therefore, I think different strategies and also center specific protocols should be developed, how we can maybe avoid, but also if there are infections, how we can probably treat those infections. And therefore, there are first single center or maybe just case reports available which describe the so-called cold atmospheric plasma therapy for the treatment of those infections. No bigger trials. That's why this idea came up with this study to do this in our patients. You can also see the problem is still in the US. Those devices do not have FDA approval yet. So those devices have CE mark approval. I know that many of those suppliers in Europe would like to enable this therapy also in the US in the next years. But therefore, we have this opportunity here. And I think this could really help us to optimize the management of driveline infections and ultimately, of course, therefore, to avoid maybe also the development of strokes, because strokes is really still one of the biggest issues we are facing in LVAD therapy. And we do know that infection is also a risk factor for strokes. And therefore, so to say, the circle is closing. If we can treat this better, I think we can have better outcomes at the end of the day.
Well, it's an important problem to solve, and you've got me excited about the possibility. But I think I ask this question for not just myself, but for many others. What exactly is cold atmospheric plasma, and what's the mechanism that it uses to actually heal some of these wounds and infections?
Yeah,
How does it
I,
work?
I, I think, Jess, that's a good question because it's not so familiar, even if in our great society of ISHLT with a lot of experts. So first of all, you can imagine the simple clarification. So you have states of matter, you have like solid, we have liquid, we have gas. That's what everybody knows, okay? So now if you're basically adding energy to a gas state, you can imagine the gas is absorbing more energy. If you have like what we are using is a therapeutic plasma gas, so you use, for example, argon gas. So if you actually have the argon gas, then absorb basically this high energy intake, then you have the plasma state. And the plasma state now is really beneficial because it has two components. If you apply this to a wound, you're not destroying basically a healthy tissue, but with a chemical part, which is actually the most important, is the most important part. The chemical part is you're creating reactive species of oxygen and nitrogen, and those are really helping in the wound area of the infected area, that you have disinfection, you have proliferation, you have angiogenesis. This is really important, and you can even, as this is a gas state, go deep inside the wound driveline tunnel. Yeah, and this is better than just using antibiotic therapy, of course. So you can also kill biofilms, and this is also multi-resistant germs which can't be killed, so to say, just by medical therapy only. A second part is also that you have, by this gas state, you have like an electromagnetic field and you have UV radiation, but this is a minor role in this therapy. So the major role is what I said before, this oxygen and nitrogen reactive species, which are really important to help in wound healing.
That was an amazing explanation. I feel like if I understand it, I know our audience is really going to understand it.
Thank
so,
you.
so, understanding how that works, can you talk a little bit about how the study will actually function, what the methods and protocols are going to be?
Yeah, so that's important. Good question. So to be honest, we thought at the beginning to do like a randomized controlled trial at the beginning, to really say, hey, you get it, you don't get it. But I think we have 1 year now to show that this is really beneficial, and we know from the first cases that it is, and we deeply believe in it. So therefore, we decided to do a different protocol. So we really applied in all of our patients having a driveline infection. Everybody here in Vienna showing up in our outpatient, especially department, will get it. So cold plasma, the nice thing is you do your standard operating procedures, basically driveline infection management, so your wound dressing, etc. It's just an add-on. It takes the therapy is once or twice a week, and one application is just for 3 to 5 minutes. So it's really short. Yeah, it's not harmful for the patient. It's not hurting the patient basically. So it can be done quickly. So we will apply this to 30 patients in the next year, showing up with driveline infection. And what we also have is those patients maybe are living not as close in Vienna, or maybe had a driveline infection the previous year, maybe, and had just with standard of care treatment. This will be approximately 60 patients. You often learn maybe in school just that you can't compare apples to oranges. Yeah?
True.
That's somehow right, but not completely, because statistically you can use like propensity score matching. So maybe you can imagine that we will pick oranges and apples, so to say, which are more or less similar. So we'll have a look to the cold atmospheric group. We have a look to patients have been treated in the standard way, and we will match those. So based on their gender, on their age, on their microbiological profile which they had in the wound. So which germs did they have? What was their BMI, etc. So meaning we will really match one-to-one, that we can actually more or less compare the cohorts. And this is an add-on to what is available now already in literature, single cases, that we really can show, is it better if we add to the drive-in infection protocols cold plasma compared to usual care? Can we actually treat those infections faster? Do we prevent also, and that's important in infection management, a reinfection? And I think what is also necessary in the field, how often do we have to apply this therapy? That's what we have to define in this study. Also for our whole community in the future, that, you know, if you have a wound which is classified this or that, you will need approximately, like, I don't know, 9 to 10 sessions of this new technology to solve your drive-in infection.
Well, that's fascinating. And, you hinted at this a little bit, just talking about what you might learn and what you're trying to learn from this. What are the relevance of those findings? And are there any other clinical and research applications that you see coming from this work, coming from this study, or maybe that you might use this cold plasma to learn about?
Yeah. So again, two things. First of all, let's talk about the Albert patients, and then second, also for the community, as we are not only facing MCS in our society, but also transplant patients. So first of all, I think, as I said already at the beginning, I hope that we can deal with drive-in infections in a faster way. Therefore, as I said, I think it's also a thing of quality of life for our patients. So if you have a drive-in infection, it hurts, you have to come to the hospital, maybe you get readmitted if it's not treated properly. So I hope that with plasma, those patients can be still outpatients. We can avoid readmissions. Therefore, it's also about costs for the hospitals, for the whole community, that we can prevent those readmissions. And of course, as I said at the beginning already, ultimately to improve the outcomes, to have less adverse events, to have less mortality. That's definitely one thing in the clinical arena. But what I can also see already here in our center is that this technology is, of course, also interesting not only for the MCS field, but just imagine for every cardiac surgery patient. Imagine if you have a sternotomy also in a transplanted patient, and you have wound infections of a sternotomy previously. You can also treat those cases, and we started this also in our center already to treat 1 or 2 cases where there were infections just of a classical wound after cardiac surgery. So that's, I think, also something we could use this technology for.
Well, the possibilities are really exciting. And I know it takes a village to do a study like this. Can you tell us a little bit about the team you're going to work with and the team that you have there in Vienna?
Yeah. So as you said already before, the beauty on this project is it's multidisciplinary, and that's why I really I like to do this now. We have, first of all, of course, our VAD coordinators. Not only me here, we have a great team of VAD coordinators which are contributing this. We have nurses, we have wound managers which are dedicated for the treatment of these Albert wounds. Of course, we have the expertise of our cardiothoracic surgeons. So what is the best stage, when to start with this therapy? Do we need maybe a wound debridement before, or can we immediately start with this therapy? Our heart failure cardiologists. Last but not least, the patients and their caregivers, they are also part of our team, and many of our students here as well. So it's really, it's a big effort. And of course, we have the support not only of ISHLT, but also of ICCAC, which both societies are enabling this project, which a lot of friends and colleagues around the globe are there to have stimulating discussions with me about the results, and hopefully we can present those results also soon at an ISHLT meeting in the next year.
Well, you took the words right out of my mouth. I'm really excited to see where this leads, and hope we'll see some results from you maybe next year in Denver, or maybe at the following meeting. Is there anything else you wanted to share about the project today, Thomas?
I think it's fine. So for me, if I'm happy. So I think it covered pretty everything.
Good. Well, thank you so much for joining me today, and for sharing all the details on the project.
Yeah. So once again, thank you very much. And once again, I would really like to thank the society for giving us this opportunity. And we're really looking forward to share the results with you guys.
Absolutely. Congratulations.
Thank you.